Two.
Hello. Hello. Hmm.
Good afternoon, everyone. On behalf of the Department of Pediatric and Preventive Dentistry, the Shmesh Institute of Research and Dental Sciences, Faridkot, we warmly welcome you all to today's webinar titled Mastering Topical Fluorides from Theory to Clinical Practice. It is truly a pleasure to have such an enthusiastic gathering of faculty members, postgraduate students, and the delegates joining us today for this academic session. Fun fact, fluoride is the only naturally occurring mineral that has been officially recognized as one of the 10 great public health achievements of 20th century. Today, we dive deep into making the most of it at the chairside.
Before we officially commence the program, I invite you all to watch a short video presentation highlighting our esteemed institution. Before we officially commence the program,
Thank you. I now take the privilege of inviting our respected Dr. Meenu Bhola, Professor and Head Department of Pediatric and Preventive Dentistry, DERTS, to deliver the welcome address.
Good afternoon, everyone. It gives me an immense pleasure to welcome you all to this academic webinar on Mastering Topical Fluorides from Theory to Clinical Practice. I extend my heartfelt gratitude to our Honorable Director, Sir, Dr. Gursevak Singh, our Revered Joint Director, Sardar Swaranjit Singh Gill, and our Honorable Principal, Sir, Dr. M.K. Sunil, for their constant support, encouragement, and guidance in organizing this webinar. To all our participants, thank you for joining us today. I hope this session offers you insights that will help you in day-to-day patient care.
thank you so much, ma'am, for your inspiring words. Now, I would like to request our respected Principal Sir, Dr. M.K. Sunil, to kindly address the gathering and share a few words.
Yeah, good afternoon, everyone. Respected our director, sir, Dr. Guruseva Singh, sir, our joint director, Swaranjit Gill, sir, and members of the committee, and my dear students and faculty members who have been joined this webinar. It's a gives a immense pleasure to welcome you all on this today's webinar. We have a renowned speaker, Dr. Nirabjit Kaur, professor and head of the Department of Aeronautics, Government Dental College, Amritsar. I welcome you, ma'am, on this August gathering and accepting our invitation for this webinar. And today's webinars, the topic is on the mesmerizing the topical fluorides from theory to clinical practice. I think everyone will agree with this particular topic. Now it is more, and you know that the fluoride contents in the regular water and everything is more, and where I think the lot of studies has been even now is going on, particularly on the defluoridation techniques and etc. So I think definitely this particular topic will show and will give more of enriched knowledge about the students and the faculty of delegates who have been participating in this webinar. I welcome you on this August gathering, madam, and I welcome our madam, Dr. Meenu Bola, who is the head of the Department of Pedodontics, who has put in a lot of effort in organizing this webinar. I welcome all the faculty members of all the department and other people and other delegates who have been enrolled for this webinar. I once again welcome all the faculty members and the students who joined this webinar. Thank you. Thank you, one and all.
Thank you so much, sir, for your motivating and encouraging words. Before we formally commence the webinar, I kindly request all the participants to keep their microphones muted throughout the session. The question and answer session will be held at the end of the webinar. Participants are requested to post their questions in the chat box, and all questions will be addressed during the discussion session thereafter. I also request everyone to refrain from using the raise hand feature during the webinar session.
I now once again invite Dr. Meenu ma'am to introduce our esteemed guest speaker for today.
It's my proud privilege to introduce today's distinguished guest speaker, Dr. Nirabjit Kaur, Professor and Head of Department of Pediatric and Preventive Dentistry at Punjab Government Dental College and Hospital, Amritsar. Dr. Nirabjit Kaur has completed both her graduation and post-graduation from Punjab Government Dental College, Amritsar, and joined the Punjab Dental Education Services in 2008. She has authored numerous publications in both national and international journals, and she is also a life member of ISPPD. Her significant contributions to pediatric and preventive dentistry, along with her commitment to teaching, has motivated and influenced countless students and professionals. Dr. Nirabjit, we are truly grateful for your presence and look forward to your valuable insights.
Thank you, Dr. Meenu. Am I audible? Hello?
Yes, ma'am, you are audible.
Okay. A very good afternoon to respected principal, sir, all the management, respected elders, Dr. Meenu, and my dear students. I feel privileged to be here as a guest speaker in your institute. Thank you for giving me this chance. So now we will start with the webinar, Dr. Meenu. We can start?
Yes, ma'am. Sure, ma'am.
Put off कर देना मुझे मेरी slide. So today's topic of webinar is Mastering Topical Fluorides from Theory to Clinical Practice. What fluoride is? Fluoride is the ionic form of the element fluorine, a halogen in the group 17 in the periodic table. So the role of fluoride in dentistry. Fluoride is regarded as the most effective anti-chirurgenic agent in dentistry, and it forms the foundation of modern preventive dental practice. Its clinical importance lies in its ability to influence the dynamic process of demineralization and remineralization, thereby preventing the initiation and progression of dental caries. So here I would like to mention what demineralization and what remineralization is. Demineralization is the loss of the minerals from the tooth, leading to the initially white spot lesions that later on further progress and give to the cavitation. And remineralization is reuptake of the essential minerals so as to reverse the process of demineralization. And it is highly helpful to, prevent the tooth from getting cavitated. Then mechanism of action of fluoride. Remineralization, fluoride enhances the precipitation of calcium and phosphate ions into partially demineralized enamel crystals, promoting remineralization. It facilitates the formation of fluoridated hydroxyapatite, that is fluorapatite, which is more stable, less soluble, more resistant to acidic dissolution. This mechanism is especially effective in reversing the incipient enamel lesions, that are white spot lesions. Usually, a white spot lesion takes approximately 2 years to get cavitated lesion. So we have a grace period during which, with the help of different remineralizing agents, we can reverse that white spot lesion. So then comes inhibition of demineralization. During chorionic acidic attacks, fluoride adsorbs onto the enamel crystal surface and it reduces enamel solubility, resulting in decreased mineral loss, reduced progression of carious lesions, and preservation of tooth structure. Then it is also having antibacterial action. Fluoride exerts antimicrobial activity by inhibiting the bacterial enzymes, particularly enolase enzyme is inhibited, which is important in the process of glycolysis in chirogenic bacteria such as Streptococcus mutans and Lactobacillus. So it ultimately reduces acid production, plaque chirogenicity, and bacterial metabolism. Then effect on the tooth development, like systemic fluoride incorporation during odontogenesis, that is during the tooth formation, it results in the formation of enamel crystals with greater structural integrity and acid resistance. Newly erupted teeth exhibit enhanced resistance to dental caries. So coming to the clinical role of fluoride. Preventive dentistry. In preventive dentistry, it leads to the primary prevention of dental caries. It arrests early enamel lesions. Then there is a reduction in caries prevalence and incidence. In our specialty, that is pediatric dentistry, it is essential for caries prevention in high-risk children. It is widely used in school dental health programs. It is important during the post-eruptive enamel maturation. Coming to the restorative dentistry, fluoride releasing restorative materials like glass ionomer cements, they provide sustained anti-chirogenic effects. It also helps in the reduction of secondary or recurrent caries. As a part of community dentistry, fluoride helps, like in community water fluoridation, it is considered one of the most successful and cost-effective public health measure for the caries prevalence worldwide. Then today's topic of discussion is mastering topical fluorides from theory to clinical. That means the knowledge regarding the topical fluorides which we have, how to be implemented in the clinical practice. The highlights of today's discussion are evidence-based topical fluoride use in clinical practice, types and applications in practice, and safety and patient compliance. Clinical applications of fluoride can be either topical or systemic. Topical means they are applied on the surfaces in any form. that could be professionally applied, which will release higher concentration of fluoride, that is 9,000 to 22,600 ppm. ppm is parts per million. Then it can be self-applied in the low concentrations, 200 to 1500 ppm. Coming to the systemic fluoridation, water fluoridation is mainly used. Then comes cool water fluoridation, salt fluoridation, and milk fluoridation. The table is given along with side in which the consumption or the fluoride, recommendation as per age and the fluoride content of that area is given. Then topical fluoride versus systemic fluorides. Topical fluorides are applied topically after the eruption of the tooth. That is post-eruptive. Systemic fluorides are applied through systemic routes during the development of dentition. Normally, high concentration of fluorides are used in topical fluoridation. In systemic, lower concentration of fluorides are used. Topical effects are seen only for shorter durations. Effects are there throughout life. Topical doesn't lead to dental fluorosis. Systemic fluorides can lead to dental fluorosis. Patient cooperation and compliance are absolutely necessary for topical fluoridation. Patient cooperation and compliances are not required. Expensive topical fluorides, yes, they are comparatively expensive. Then the systemic fluorides are cost effective and cheaper. Normally, topical fluorides are applied professionally, or sometimes they can be used by the patients like dentifrices, mouth rinses. Systemic fluoride self-application is not possible. Then indications of topical fluoride therapy as seen in the pictures. Number one, high risk caries, then newly erupted permanent teeth, incipient non-cavitated carious lesions, special health care need patients, then incipient carious lesions, white spot lesions, orthodontic patients with white spot lesions, then xerostomia patients. So I feel there are, junior students also attending the seminar. Xerostomia is a condition in which the salivary flow is decreased. So when salivary flow is decreased, it automatically leads or makes the patient prone to caries attack. So, and in those cases, topical fluoride therapy is highly beneficial. Then the objectives of professionally applied fluoride therapy. It will lead to the prevention of dental caries. It helps in the enhancement of remineralization, reduction of enamel demineralization, and remineralization of the incipient carious lesion. As I already told that we have a grace period of approximately 2 years for an incipient carious lesion to develop to full cavitated lesion. We can take the help of these professionally topical applied fluoride therapy to reverse that lesion. Then the indications for topical fluoride therapy are patients with high caries activity, children and adolescents with newly erupted teeth, orthodontic patients, xerostomia patients, individuals with poor oral hygiene, root caries susceptibility, patients with special health care needs, patients undergoing radiation therapy. However, there are certain contraindications too, like low caries risk patients, history of fluoride hypersensitivity, young children with poor swelling reflex, acute ulcerative gingivitis or stomatitis, and patients with fluorosis or endemic exposure. Then the available forms of topical fluorides are in the form of solutions in which they have sodium fluoride, stannous fluoride, or APF. Then method of application is usually with the cotton applicator or paint-on technique, gel, foam, APF. It is usually applied with a tray. Then varnish, which are painted with a microbrush, and antifreezes, toothpastes, which can be used by the patient at home, and the mouth rinses. Commonly professionally applied fluoride agents are sodium fluoride, acidulated phosphate fluoride, stannous fluoride, fluoride varnishes, and silver diamine fluoride. Sodium fluoride therapy. Sodium fluoride is widely accepted following the work of Knudsen. Common professional concentration of sodium fluoride used is 2% sodium fluoride, which contains approximately 92 parts per million fluoride. It gives a neutral pH. Caries reduction in first year was seen to be 45%, and in second year it was 36%. So sodium fluoride is usually valued for its safety, stability, neutral pH, and for its proven anti-carcinogenic efficacy. Knudsen technique is the most recommended technique in which 2% sodium fluoride solution is applied topically. Usually 4 applications are done at weekly intervals. The recommended frequency is 3, 7, 11, and 13. And this particular pattern has the basis that it is initiated around at the age of 3 years when primary dentition is completed. Then at 7 years of age, after the eruption of permanent first molars and incisors to help those teeth. Then at the age of 11 years, usually when the mixed dentition is there, and at 13 years, eruption of the all permanent teeth. The rationale for this particular protocol is to coincide with the eruption periods of the susceptible teeth, allowing maximum post-eruptive enamel maturation and fluoride uptake. So the technique is usually done as oral prophylaxis, means scaling and polishing has been done earlier. Before this application, then teeth are isolated and dried. Then 2% sodium fluoride solution is applied using cotton applicators or trays, and it is maintained for 4 minutes. Then patient is instructed to avoid eating, drinking, rinsing immediately after the application for 30 minutes. Method of preparation of sodium fluoride. It is prepared by dissolving 20 grams of sodium fluoride powder in 1 liter of distilled water in a plastic bottle. It is essential to mention here that it should be stored in the plastic bottles, because if stored in glass containers, the fluoride ions of solution can react with the silica of glass, forming SiF2, thus reducing the availability of free active fluoride for the anti-caries action. So the mechanism is application of 2% sodium fluoride, which will release fluoride ions. Then it will lead to the formation calcium fluoride plus hydroxyapatite will form fluorapatite. That is a fluoride reservoir with increased acid resistance, leading to remineralization and reduced enamel solubility. Along with that, giving antibacterial effect because of the decrease in the process of glycolysis and decreased acid production. That also then eventually leads to the prevention and arrest of the dental caries. Then choking off effect is like when sodium fluoride is applied topically, it reacts with the hydroxyapatite crystals to form calcium fluoride, the dominant product of the reaction. Choking off effect occurs because once a thick layer of calcium fluoride is formed, then it will interfere with the further diffusion of fluoride from the topical fluoride solution to react with hydroxyapatite. That is why it is left to dry for 4 minutes. Calcium fluoride reacts with hydroxyapatite to form fluoridated hydroxyapatite, which increases the concentrations of surface fluoride. It makes the tooth structure more stable and less susceptible to dissolution by acids. It interferes with plaque metabolism through anti-enzymatic action. It also helps in remineralization of the initial decalcified areas. So choking off effect refers to the phenomena in which excessive surface precipitation of calcium fluoride or fluorapatite blocks further penetration of the fluoride ions into the deeper enamel layers. Then the advantages of Knudsen regime are, it is scientifically proven to be reduced, in the caries reduction. It is safe and economical. Neutral pH, that is non-irritating to the oral mucosa, suitable for children, compatible with restorative materials. But there are certain limitations too. That means that requires multiple appointments. We need patient compliance. Patient has to be recalled for 4 times. Then time consuming also, superseded today by fluoride varnishes and APF gels in many clinical settings. The Knudsen regime laid the foundation for the modern professionally applied fluoride therapy, and it remains a landmark protocol in preventive dentistry for systematic caries prevention. Coming to the another topical fluoride, that is stannous fluoride. Stannous fluoride is a topical fluoridating agent that is used for caries prevention and control of enamel demineralization. It is one of the earliest and most biologically active fluoride compounds used in dentistry. So its single annual application reported 32% caries reduction. Molars technique is a method in which we apply stannous fluoride. The method of preparation of stannous fluoride is it has to be freshly prepared before each time, because stannous form of tin gets oxidized to stannic form, thus making the stannous fluoride inactive for anti-caries action. So it has no shelf life. For convenient preparations, gelation capsules are filled with 0.8 grams powdered stannous fluoride and are stored in airtight plastic containers. Just before application, the content of one capsule is dissolved in 10 ml of distilled water in a plastic container, and the solution thus prepared is shaken briefly. Then the solution is applied immediately to the teeth. 10 ml of the solution should be sufficient to treat the whole mouth of the single patient. If any solution is left, then it should be discarded and it should not be reused. Method of application of stannous fluoride, again thorough prophylaxis should be done. That involves scaling and polishing. And the teeth are isolated with cotton rolls and dried preferably with the compressed air. Either quadrant or half of the mouth can be treated at one time. Quadrant to be treated should be kept free of saliva, and if possible, a saliva ejector should be used. Freshly prepared 8% solution of stannous fluoride is applied to the teeth with cotton applicators. Teeth are kept moist with the solution for 4 minutes. A reapplication of solution to a particular tooth is done every 15 to 30 seconds. The recommended frequency of 8% stannous fluoride application is once per year. So here I would like to mention to specifically to the interns, if they are attending this webinar, that you should learn these values. Stannous fluoride percentage, the recommended frequency, once per year, twice per year, nuts and technique, 4 applications, because these are the important points that you should be keeping in your mind while preparing this topic, as these are the usually asked multiple choice questions. Coming to the mechanism of action of stannous fluoride, it reacts with hydroxyapatite in addition to fluoride. The tin of stannous fluoride also reacts with enamel and a new crystalline product gets formed, that is stannous trifluorophosphate. Rapid penetration of tin and fluoride in 30 seconds occurs, therefore reapplication after 15 to 30 seconds is needed. In addition to stannous trifluorophosphate, 3 more additional products are formed: stannous hydroxyphosphate, calcium fluoride, and calcium trifluorostenate. The advantages are strong anti-caries agent, this broad antimicrobial spectrum, desensitizing action, better enamel uptake than sodium fluoride. Disadvantages, it causes extrinsic staining, brown or black discolorations. Then metallic taste due to stannous hydroxyphosphate. It's unstable in aqueous solution, have to be prepared fresh every time. Short shelf life. It may irritate oral mucosa in some cases. It can cause staining on the margins of the restorations. So the clinical uses are for caries prevention, for hypersensitivity treatments, root caries management, and high caries risk patients. It's available in toothpaste, most common gel that is professionally applied, and varnish, less common due to the stability issues. Then coming to the third type, that is acidulated phosphate fluoride. APF is one of the most commonly used professional topical fluoride preparation used for caries prevention, especially in children and high-risk patients. APF solution or gel usually contains 20 grams of sodium fluoride and fluoride ion, usually 1.23%, giving 12,300 ppm of fluoride. Students, you must learn these values. There's how many ppm are released by which type of fluoride. Then hydrofluoric acid plus phosphoric acid buffer system, giving pH, acidic pH, that is 3 to 3.5. Flavoring agents, that could be any artificial fruit flavors, plus thickening agent like methyl cellulose in the gel form is used. The acidic pH is the key for enhancing enamel uptake. APF gel and solution, comparing them both, gel is relatively costly, solution comparatively cheap. Gels are readily available. Solution can be prepared easily. The advantages of being used as self-application, solution has to be applied topically by a dentist or the auxiliary staff. And method of preparation, contains 1.23% of fluoride in 0.1 m phosphoric acid at a pH of 3 and is stable with long shelf life when stored in opaque plastic bottles. It's prepared by dissolving 20 grams of sodium fluoride in 1 liter of 0.1 m phosphoric acid. To this is added 50% of hydrofluoride acid to adjust the pH at 3 and fluoride concentration at 1.23%. For the preparation of APF gel, a gelling agent, methyl cellulose or hydroxyethyl cellulose is to be added to the solution and the pH is to be adjusted between 4 to 5. Method of application, again after oral prophylaxis, the teeth are isolated with cotton rolls, dried, and APF solution is continuously and repeatedly applied with cotton applicators, and teeth are kept moist for 4 minutes. Floss may be drawn through each interproximal embrasure to ensure wetting of these surfaces. The recommended frequency of APF topical applications is semi-annually. APF gel may be applied in the same manner as topical solution, but APF gel can be used by self-application procedure. A variety of self-reusable disposable trays in various sizes together with sponge-like trays or liners are available. Method of application of gel form. The quadrants are isolated on both buccal and lingual side with cotton rolls. For application of gel, position the patient upright and provide saliva ejector. Place enough gel to fill 1/3 of the trough area of the tray so that it is sufficient to cover the dental arches. Place loaded tray over the arch and squeeze over buccal and lingual surfaces, forcing the gel between them, and allow the tray to remain in the mouth for 4 minutes. Then instruct the patient to expectorate immediately and avoid eating and drinking for next 30 minutes. The recommended frequency of APF topical application is semi-annual. So mechanism of action is when APF is applied to the teeth, it initially leads to dehydration and shrinkage in the volume of hydroxyapatite crystals, which on hydrolysis form dicalcium phosphate dihydrate. This DCPD, which is highly reactive with fluoride, starts forming immediately when APF is applied, and fluorides penetrate into the crystals more deeply through these openings produced by the shrinkage and leads to the formation of fluorapatite. Fluorapatite, as I already told, is more, resistant to caries and acid attack. The amount and depth of fluoride deposited as FAP, fluorapatite, would be dependent on the amount and depth at which the DCPD gets formed. Since for the conversion of the whole DCPD so formed into FAP, deeper penetrations and continuous supply of fluoride is required. So APF has to be applied every 30 seconds and the teeth is to be kept wet for 4 minutes continuously. Advantage is it has acceptable taste, no staining, no gingival irritation, stable with long shelf life, comparatively cheap. Disadvantages: teeth have to be kept wet for 4 minutes continuously. Solution is acidic. Then here is the table in brief, which is showing the comparison of the 3 types of these sodium fluoride, stannous fluoride, and APF. The percentage used is 2%, 8%, and 1.23%. Fluoride concentration released is 9200 ppm by sodium fluoride, stannous fluoride, and APF. Then frequency of application, sodium fluoride has to be applied 4 times at 3, 7, 11, and 13. Stannous fluoride biannually and APF biannually. pH, it has neutral, acidic, and there are no adverse effects. Tooth pigmentation in case of stannous fluoride, and there is no pigmentation in case of APF. Caries reduction is 30% by sodium fluoride, 32% by stannous fluoride, and 28% by APF. Then coming to the fluoride varnishes. According to the American Academy of Pediatric Dentistry, fluoride varnish is a highly concentrated topical fluoride agent designed to be painted onto the tooth surfaces, which sets upon contact with saliva. It acts as a slow-releasing reservoir of fluoride. It acts as a slow-releasing reservoir of fluoride to enhance enamel remineralization. inhibit demineralization, and reduce bacterial metabolism. The two most commonly used varnishes are Durafit and Floor Protector. Composition of Durafit. It is a sodium fluoride in varnish form containing 22.6 milligram of fluoride per ml, that is 2.26% suspended in an alcoholic solution of natural organic varnishes. It is available in bottles of 30 ml suspension containing 50 milligram of sodium fluoride per mg. The active fluoride available is 22,600 parts per million. Then floor protector is a colorless floor silane in a polyurethane. The fluoride content in floor protector is 0.7% by weight and active fluoride available is 7,000 parts per million. The review by Merino et al. Showed that the clinical efficacy of fluoride varnish showed decrease in caries by 35% for primary teeth and by 45% in permanent teeth. In terms of efficacy of varnish, according to Seppa et al., Durafit is more effective as compared to floor protector. Green et al. Proved that, he concluded that Durafit and floor protector are equivalent in their efficacy. According to Levi et al., Durafit is comparatively a bit less than floor protector. So here is the technique of varnish application. After prophylaxis, teeth are dried but not isolated with cotton rolls. So here it should be noted that in the last, where we were using all the solutions, we were, giving the isolation with the cotton rolls. The point to be noted here clinically is that these are not to be isolated with the cotton rolls. A total of 0.3 to 0.5 ml of varnish equivalent to 6.9 to 11.5 milligram fluoride is required to cover the full dentition. The application is done first on the lower arch and then on the upper arch with the help of single tufted small brush. After application, the patient is made to sit with mouth open for 4 minutes before spitting to let the Durafit varnish set on the teeth, which is further enhanced by the moist environment created by the saliva. The patient should be clearly instructed not to rinse or drink anything at all for 1 hour and not to eat anything solid but take liquids and semi-solid only till the next morning. So then coming to the silver diamine fluoride, SDF. SDF is a colorless topical liquid solution composed of 38% silver diamine fluoride that is widely utilized in pediatric dentistry as non-invasive, painless alternative to traditional cavity drilling. It contains approximately 24 to 28% silver, acting as a powerful antimicrobial agent, and 5 to 6% fluoride, promoting enamel and dentin remineralization, providing about 44,800 ppm of fluoride ions to effectively arrest the active dental caries. It targets tooth decay by 3 distinct mechanisms. First of all, it has an antimicrobial action. That is, silver ions destroy the cell walls of the pathogenic bacteria to stop active infections. Remineralization, high concentration of fluoride ions rebuild and harden compromised enamel and dentin. In enzyme inhibition, the compound blocks the specific enzymes and that break down the tooth structural collagen. Paint-on technique of SDF, clinical steps: isolate the tooth with cotton rolls or gauze, remove gross debris and dry lesions gently, protect adjacent gingiva and lips with petroleum jelly, because if it touches those areas, it can cause staining. Then dispense 1 drop of SDF into the Depin dish. Then dip microbrush in SDF and apply to the lesion, paint-on technique. Allow to contact for 1 to 3 minutes. Then excess material should be blotted off. Then advise the patient not to eat or drink for 30 minutes. It can be reapplied at the periodic intervals, commonly 6 months. The advantages of SDF: it is a non-invasive and painless technique. No drilling or local anesthesia is required. Rapid application technique. It is highly effective in arresting caries, cost-effective and easy to use. It is useful in very young or medically compromised children. then reduces bacterial load and dentinal sensitivity. It is ideal for outreach and public health programs. However, certain disadvantages like it can cause permanent black staining of the carious lesions. It has a metallic or bitter taste, temporarily gingiva or mucosa irritation if improperly applied. It does not restore tooth form or function. Aesthetic corner, I mean, we have to do some kind of filling after application of it. If cavitated lesion has to be stopped from further progress, you can paint on SDF, but restorative part has to be done additionally. So it is not restoring the tooth form or a function. An aesthetic concern in case of anterior teeth requires periodic reapplications and follow-ups, contraindicated in silver allergy and ulcerative gingival conditions. So a systematic review by Farahi et al. In 2026 concluded that compared with sodium fluoride, 38% silver diamine fluoride increases the likelihood of arresting early childhood caries lesions while producing similar effects on DMFS. Clinical selection should balance lesion size, self-applied topical fluorides. Self-applied topical fluorides are the fluoride-containing preparations that are used by the individuals at home under professional guidance to enhance enamel resistance and prevent dental caries through regular low-dose exposure. The common forms are fluoride toothpastes that could be, containing sodium fluoride, sodium monofluorophosphate, and stans fluoride. Fluoride mouth rinses with the daily uses having a concentration of 0.05% sodium fluoride and weekly use 0.2% sodium fluoride. Fluoride gels and pastes that can be used at home but under specific supervision. Then fluoridated dentifrices. Commonly, fluoride compounds in dentifrices is sodium fluoride, sodium monofluorophosphate, or stannous fluoride. The fluoride concentration in your toothpastes usually is 900 to 1100 ppm of fluoride. The toothpaste, any toothpaste, Colgate, Close Up, any toothpaste you go and check, it would be having 900 to 1000 or 1100 ppm of fluoride. हर एक के पीछे लिखा हुआ होता है. And in case of pediatric patients, the prescription like Kidodent or Colgate kit जो आती हैं, they usually have a fluoride concentration of 400 to 500 ppm. And then the AAPD recommendations for fluoridated dentifrices. The use of fluoridated dentifrices is recommended as per the age group. Less than 3 years of age, recommended amount of fluoride toothpaste is smear or grain of rice-sized amount. And the recommendation is to brush twice daily under parental supervision. For the age group of 3 to 6 years, a pea-sized amount is prescribed and it should be supervised brushing to minimize swelling. Then more than 6 years of age is a regular amount and encourage spitting after brushing with the proper rinsing. So caries reduction by different types of applications of topical fluorides are with the fluoride varnish using 5% sodium fluoride, the caries reduction in primary teeth is 37% and in permanent is 43 to 47%. Fluoride gels using 1.23% APF have shown the reduction to be 20 to 21% in primary teeth and 28 to 38% in case of permanent teeth. Fluoride mouth rinse program 0.05 daily or 0.2% daily leads to 27% of caries reduction. Fluoride toothpaste containing 900 to 1100 ppm. In case of pediatrics, it would be 400 to 500 ppm. And the caries reduction with fluoridated toothpaste is 24 to 44% in case of primary teeth. And in case of permanent teeth, it would be, it has been, calculated as 24 to 44%. SDF silver diamine fluoride 38% solution has shown to be much effective, leading to 66 to 81% reduction or arresting of active caries lesion in case of primary teeth and 25% to 71% of root caries. Coming to the fluoride toxicity refers to the harmful effects caused by the excessive ingestion of fluoride over a short or long period. It could be acute and chronic. acute occurs due to sudden ingestion of large amount of fluoride, commonly in children. Usually, small children जो हैं, they usually ingest a larger amount of fluoride toothpaste. In lieu to the taste, they just have it more, and fluoride toxicity can occur, leading to nausea, vomiting, abdominal pain, diarrhea, excessive salivation, muscle spasm, and in severe cases, it can lead to respiratory or cardiac failure. So the management is to induce vomiting if conscious and administrate milk or calcium preparation and provide immediate care. Usually fluoride toxicity आप लोगों के नेबरहुड में हो सकती है, बच्चे ने आधा पेस्ट खा लिया, कुछ कर लिया, then you being into the dental course should be knowing कि अगर कोई बच्चा या कोई गलती से ज्यादा टूथपेस्ट खा ले, then immediate treatment is to give milk or to induce vomiting. Coming to the chronic fluoride toxicity, it results from prolonged exposure to high fluoride levels, usually through drinking water. It can lead to dental fluorosis and skeletal fluorosis. So coming to the conclusion, topical fluorides remain one of the most scientifically validated and clinically effective measures for the prevention and control of dental caries. Appropriate selection of fluoride agents, correct application techniques, risk-based patient assessment, and adherence to the preventive protocols significantly enhance therapeutic outcomes while minimizing the adverse effects. Ultimately, the integration of topical fluorides into routine clinical practice represents a cornerstone of preventive dentistry, contributing to the long-term oral health promotion and minimally invasive patient care. Thank you.
Thank you so much, ma'am, for such an insightful and enlightening lecture. It was truly a valuable learning experience for all of us. Now we have received some wonderful questions from our participants in the chat, and we'd love to take up a few of them. So the first question comes from one of our participants who would like to know that is there an age or clinical situation in where topical fluoride application is no longer beneficial, like we should consider discontinuing it.
So ideally, if we say there is no age-related contraindication regarding the non-uses of topical fluorides, they are usually effective in all age groups. In pediatric population, usually newly erupted either primary or permanent dentition is there, which need fluoride, topical fluorides. If we talk about the old age groups, there is usually recession, root caries, so they need fluoride for remineralization of those new appearing, lesions. Otherwise, medically compromised patients could be on any kind of drug therapy, so reduced saliva could be there. So ideally, if we talk, there is no specific age for that fluoride application topically is contraindicated. But however, yes, depending upon certain situations, like in case where there is some kind of oral mucosal, ulceration is there, or the patient is not fit, there are some other kind of systemic issues at that time, there we can, we can say that at that particular point of time, topical fluoride therapy is not advisable. But otherwise, starting from, a child who is having a primary dentition, permanent dentition, and old age groups, it is usually beneficial only. So we can stop or say no only in case of specific clinical conditions.
Thank you so much, ma'am. Another one of our participants has asked that in case there's a high caries risk child, and if he's already using fluoride toothpaste, are additional in-office applications still necessary, or are we over-fluoridating?
So if the child is already having, you are saying two things. One is the child is already a high caries risk child. That means he is having ECC type 2 or 3. He is having multiple caries lesions in his oral cavity. So the reasons for that could be either the oral hygiene is not good, or if he is already having a toothpaste containing fluoride, he is not being monitored properly by the parents. That means आपको बताने के लिए है कि बच्चा फ्लोराइड वाला टूथपेस्ट यूज कर रहा है, बट एक्चुअली द चाइल्ड इज नॉट यूजिंग बिकॉज मोस्ट ऑफ द पेरेंट्स डू नॉट नो हाउ टू गाइड देयर चाइल्ड टू डू ब्रशिंग विद प्रॉपर पेस्ट. So yes, definitely, if a child, if he or she is actually already using fluoridated toothpaste, but coming to the pediatric department with high caries risk, multiple caries teeth, we do need to apply topical fluorides because we are applying, if he is coming under nuts and technique, then we will be applying for 3, 7, 11, 13. As per that protocol. Otherwise, we will be using everything in our control and only for the benefit of the child. So it is not going to do any kind of fluoride toxicity or additional damage because actually on paper he is having fluoridated paste, but if he would had been using it properly and along with oral hygiene instructions and care, then he would not had come under the high caries risk. So understand, it is required. They are always beneficial.
Thank you, ma'am. We'll just take up one more question. What is your approach when a parent is apprehensive about fluoride toxicity?
So when we have to, prescribe any parent about the topical fluoride application, they must have heard about the fluoride toxicity. We need to make the parent convinced and we need to guide them properly that it is not going to do any kind of harmful effect when we are giving it under our control. So we need to explain the parent that it is dose related. Normally, whenever we will be doing topical fluoride application, limited amount and in a prescribed manner would be done. That is not going to create any kind of fluoride toxicity. So patients are always apprehensive. Parents are always apprehensive even for getting the fillings done. They're always apprehensive for getting the root canals done, but we need to convince them. Rather, parents are always apprehensive to get the primary teeth treated. They would come and say that ये तो दूध वाला दांत है मैडम जी, ये तो निकल ही जाना है, इसकी क्या जरूरत है. So every time we as pediatric dentists, we need to convince the patient that primary teeth form the base of the whole dentition. So they should be preserved. Likewise, if it is required, it is required. Means if topical fluoride application is required, it has to be done. So patient has to come out of that fear. We need to convince the parents that yes, your child needs it, and no kind of harmful effects are going to occur with this kind of fluoride therapy.
Thank you, ma'am. Due to time constraints, any remaining questions will be addressed personally via email. So please do watch your inboxes. Now, I humbly request Dr. Ekta Thakkar, Professor, Department of Pediatric and Preventive Dentistry at the Shmesh Institute of Research and Dental Sciences, Faridkot, to share a few words.
Good afternoon, everyone. On behalf of the department, I would like to express our heartfelt gratitude to our esteemed guest speaker for such an informative and engaging session. Your valuable thoughts and guidance truly enhanced our knowledge and inspired us all. I would also like to sincerely thank our respected principal and management for giving us this wonderful opportunity to organize this webinar. Their constant support and encouragement made this event possible. Thank you, everyone, for your participation and presence.
Thank you, ma'am. Now we invite our principal, sir, Dr. M.K. Sunil, once again to present the certificate of appreciation on behalf of everyone at DERTS to our esteemed guest speaker, Dr. Neerajit Kaur, as a token of our gratitude.
A very good afternoon, one and all. Definitely, ma'am. I missed out some of the points, but overall, I was there continuously in my system. I was hearing about your lecture. Ma'am, I have one doubt. If the crowd permits, if madam permits, one small question.
Yes, sir, sure.
See, I have been seen very endemic areas. I worked in a fluorosis zone in
Yeah.
my career. I was a Lions Club member in
Okay.
my district. So I was actively participate in the thing. I've been attended the defluoridation programs also.
Yes,
So,
sir.
but thing is, particularly when we child the child with a fluorosis, so
Yeah.
definitely we refer to the any doctor, particularly the specialist. So they say that apply topical fluorides and all those things, prevention, etc. So, do you think that is there any this topical fluorides or fluoride will does really helpful for the kids in that particular stage,
Yes,
particularly
sir.
when there is
Yes,
a
sir.
more
If
fluorosis cases, type
yeah,
1,
yeah,
type 2, particularly.
yeah. So
Yeah,
in cases of fluorosis, so there are different stages. If
yeah,
there
yeah,
is a pitting, so
yeah.
that pitting will eventually lead to carious cavitation.
Okay. Yeah,
So topical fluoride will help to remineralize those pitted enamel areas. So
yeah.
सिस्टेमिक फ्लोरिडेशन ओवर फ्लोरिडेशन की वजह से जो लॉस होना था सर वो तो हो चुका है
हो
सो
चुका है,
दीज
correct.
यस वो तो हो चुका है सो अब वी हैव टू प्रिवेंट द कैविटेशन सो
Exactly.
ऑलरेडी pitted enamel is weak that is more susceptible to caries so
Yeah,
prevent that pitted और I mean जो already हमारा हो गया है उसको remineralize करने के लिए to make that I mean stable form we need topical fluoridation it is never going to
yeah,
be harmful so
yeah.
systemic fluoridation has done its effect as fluorosis, but fluorosis wale teeth will eventually lead to the carious tooth. To
Yes.
prevent them, to I mean preserve them from getting carious or cavitated, we need this topical fluoridation.
Hello. Thanks for enlightening us about the topical fluorides and the various modalities, various products which you have been highlighted, and really very much thankful. I think everybody who has been joined this webinar will be definitely beneficial, and they might enrich the knowledge about the topical fluorides. Thank you so much, ma'am, for accepting our invitation to be part of our series of webinar. And
Thank
I
you, sir.
thank
I
to kindly
yeah.
accept our certificate of appreciation from our college side, from Dashmesh College of Institute of Research and Dental Sciences. And I thank to our Dr. Meenu Madam and his team and her team who have supported in organizing this series of webinar. Thank you so
Thank
much.
you so much, sir. I would like to
Thank
thank
you.
you, Principal Sir, Dr. Meenu,
Thank you.
and the whole management and the associated staffs in organizing and managing this whole event. Thank you
Yeah.
very much. Thank you.
Thank you, ma'am. Thank you so much.
Thank you.
Thank you, ma'am. Now, I would like to invite Dr. Samarpreet Kaur, Assistant Professor in the Department of Pediatric and Preventive Dentistry, the Smash Institute of Research and Dental Sciences, Faridkot, to conclude this wonderful session.
Good afternoon, everyone. As we come to an end, I would like to express my sincere appreciation to all the participants who enthusiastically engagement truly made today's session a resounding success. A special word of thanks to my colleagues, our postgraduates and interns who have worked diligently behind the scenes from planning and coordination to such a seamless execution. Also, I would like to inform all the attendees that e-certificates will be sent to your registered email addresses. Lastly, thank you once again, everyone, for joining us and making this event memorable.